Hereby, I open this academic ceremony at Maastricht University. First of all, I welcome Mrs. Francesca Torresan. She will defend her thesis, Excess Aldosterone as a Mechanism of Resistant Salt-Sensitive Arterial Hypertension. And I welcome all the members of the degree committee, in particular the three supervisors, Professor Kroon, he is Professor of Vascular Internal Medicine at Maastricht University. Professor Rossi, he is Professor of Medicine at the University of Padova in Italy. And Professor Jacobone, he is Professor of Surgery at the Department of Oncology and Gastroenterology, also of the University of Padova, Italy. And I will introduce the 5 opponents later during the ceremony. And I welcome, of course, all the followers of the live stream. Mrs. Torresan, may I invite you to give a summary of your thesis? Please go ahead.
Highly esteemed prorector, professors and colleagues, thank you for the opportunity to summarize the main findings of my PhD thesis that focused on excess aldosterone and salt-sensitive and resistant arterial hypertension. Arterial hypertension affects more than 1 billion people worldwide and accounts for 30% of premature death. However, less than 1 in 5 people with hypertension has the problem under control, according to the World Health Organization. Therefore, the American Heart Association, the European Society of Cardiology and Hypertension have introduced the term drug-resistant hypertension to define a specific subset of patients with hypertension that do not achieve the target levels of blood pressure recommended, despite the use of 3 or more drugs at optimal or best tolerated doses, including a diuretic. Minimal differences between the 2 definitions. And the prevalence of resistant hypertension is about 20%, with an even higher cardiovascular risk to non-resistant hypertension. However, the term drug-resistant hypertension should be used only as a provisional term until the cause of hypertension is found. And that occurs typically in the secondary forms of hypertension, of which primary aldosteronism is the most prevalent, with an estimated prevalence of 11%. And by looking at the issue from a different perspective, the rate of resistant hypertension in the aldosteronism population is about 20% or even higher, as shown by this large international multicentric study. So the first of this doctoral thesis was to verify if primary aldosteronism can be identified by adrenal vein sampling in resistant hypertensive patients who, by definition, are on multiple interfering drugs, and to test if adrenalectomy can resolve blood pressure resistant to treatment in those resistant hypertensive patients with primary aldosteronism. So as reported in chapter 2, we enrolled selected a cohort of resistant hypertensive patients from a large population of consecutive patients referred for difficult treat hypertension. And among these patients, those who wish to achieve surgical cure and those who have at least 1 clue of primary aldosteronism and adrenal vein sampling without stopping or withdrawing antihypertensive medications. And notwithstanding this, AVS succeeded in 80% of cases and showed a lateralized primary aldosteronism in 1/3 of cases that underwent unilateral laparoscopic adrenalectomy, and pathology revealed the CP11B2 positive adrenocortical adenoma in all patients. And after surgery, a significant reduction of blood pressure levels, both in systolic and diastolic blood pressure, as well as the normalization of serum potassium level and aldosterone-renin ratio was observed, with a complete biochemical outcome achieved in 96% of patients and an improvement in the clinical outcome in all patients according to the PASO criteria. And more importantly, the blood pressure values brought down to target level despite the significant reduction of antihypertensive medications in terms of both number of drugs and daily doses, demonstrating the resolution of blood pressure resistant to treatment in all patients. And these changes were parallel a significant regression of the cardiac damage, thus lowering the overall cardiovascular risk in these patients. And in chapter 3, we assess the impact of surgery on health-related quality of life in both the physical and mental component and the depression status in 26 unilateral primary aldosteronism patients before and after adrenalectomy. And the data showed a significant improvement in the physical component of health-related quality of life at long term after surgery, and a significant improvement in the mental component and the depression status at 1 month after adrenalectomy and at long term follow-up, suggesting the beneficial effect of adrenalectomy in these patients. So to summarize, adrenal vein sampling is feasible and allows the identification of unilateral primary aldosteronism in resistant hypertension patients despite the use of multiple antihypertensive drugs, potentially confounding adrenal vein sampling. And that unilateral guided adrenalectomy allows the biochemical cure of primary aldosteronism and the resolution of resistant to treatment hypertension in the patients. And the second issue addressed by this thesis was the role of salt in the pathogenesis of arterial hypertension. The first hypothesis was proposed by Guyton about 30 years ago, suggesting the central role of the kidney in the regulation of blood pressure by perfectly matching salt and water intake to urinary sodium and water excretion. However, recent studies highlighted the role of other extrarenal mechanisms in the regulation of blood pressure, and in particular the role of the skin as a of non-osmotic sodium. And in particular, in presence of high salt intake, sodium seems to accumulate in the interstitium of the skin, and this hypertonicity would induce macrophages activation via tone BP, a vascular endothelial growth factor, a potent user of lymphatic vessels, thus promoting sodium clearance. And whenever they blocked any of these steps in small model, the result was a salt-sensitive high blood pressure phenotype. And thus, besides the kidney, the skin tissue, the immune cells, and the lymphatic vessels would act as systemic regulators of blood pressure. And in fact, a accumulation was indirectly observed by the 23 sodium magnetic resonance in the skin, here in white, and in muscles, aged and hypertensive patients, and also in many other chronic diseases. So in chapter 4, we thought to use primary aldosteronism, the paradigm of salt-sensitive arterial hypertension, where sodium and water retention play a key role, to investigate feasibility of measuring sodium, potassium, and water content in human skin ex vivo, to provide direct histochemical characterization of sodium compartment in primary aldosteronism patients, and to verify if adrenalectomy improves skin sodium clearance in these patients. So between 2018 and 2019, we enrolled 25 unilateral primary aldosteronism patients that underwent the first skin biopsy at the time of adrenalectomy and the second skin biopsy 1 month after adrenalectomy for within patient comparison to investigate the effect of surgery on skin sodium, potassium, and water content. And we took also biopsies from 6 hypertensive patients and 8 normotensive subjects undergoing surgery for benign diseases to be compared to those with the primary aldosteronism. So the free 4 millimeter skin punch biopsy was immediately frozen to measure water content by gravimetric assessment and sodium and potassium content by spectrophotometry. And the results showed that primary aldosteronism patients have significantly higher skin sodium concentration compared to normotensive patients, while the skin potassium concentration and water content did not differ between the three groups. And interestingly, after surgery, significant reduction of skin sodium concentration, as well as a significant increase in skin potassium concentration and water content was observed, suggesting the reversibility of skin sodium accumulation in these patients after renalectomy. And following previous findings and our promising data, we collected also biopsies for immunohistochemistry analysis, and we validate a protocol an immunofluorescence protocol to determine the skin macrophages infiltration here in green and their activation via TONE-BP here in red. Studies are ongoing to confirm this data on a larger data set. So this finding demonstrates for the first time that the primary aldosteronism patients higher skin sodium content compared to normotensive subjects, and that the surgical cure of hyperaldosteronism resulted in the correction of interstitial skin sodium accumulation in primary aldosteronism. And finally, in chapter 5, we presented a protocol and multicentric study in order to study the skin sodium, potassium, and water content in fibromuscular dysplasia at different time points before and after renal artery revascularization in order to study the role of angiotensin system activation in skin sodium accumulation. So to conclude, subtiming primary aldosterone in resistant hypertensive patients is feasible and allows the resolution of blood pressure resistant to treatment in those with unilateral primary aldosteronism. Skin sodium storage in the interstitium seems to be reversible after unilateral adrenalectomy in primary aldosteronism, suggesting that tissue sodium accumulation could be mechanistically related to the development of hypertension. Of course, further studies are needed to confirm the role of skin interstitium and the molecular mechanism involved in the pathogenesis of hypertension. Thank you for your attention, and I give the word back to the prorector.
Thank you very much. Thank you very much, Mrs. Torresan. The opposition will be opened by the chair of the Thesis Assessment Committee, Professor Stehauer. He's Professor of Internal Medicine at Maastricht University. Professor Stehauer.
Thank you, Prorector. Dear candidate, let me start by congratulating you and your supervisors on this work. I'd like to focus on chapter 4 about skin sodium. It's really a fascinating chapter. It's a fascinating story also. It's nice that you point out that this whole concept of skin sodium is not 10 years old, but about 100 years old. Like many things in physiology, things come back. Nevertheless, you make a very nice attempt to look at this problem with novel methods in also a novel question about aldosteronism. So my first question really is, and if I look at page 74, you use skin biopsies, and then you did lots of procedures on this skin biopsy. Did you actually do that work yourself, or did you have technical support, or were lab technicians involved in that, or what did you do yourself after the skin biopsy, and what was left to technicians?
esteemed opponent, thank you for the question. I was involved in all the process, but of course I had technical assistance for a particular from a biologist that that worked with our team, and so what I did, I select the patients in. So I worked in the selection of those primary aldosteronism that the patients that then were candidate to unilateral adrenalectomy, and then I was in touch with this biologist. So when we scheduled the operation, I talk with the biologist. So we were basically a team. So she came with the liquid nitrogen in the operative room, and then when I took the took the first biopsy, and then we immediately frozen this biopsy. I did the biopsies to her, and then we stored these specimens in in the lab, and when we collected all the specimens, then I went with her to weight these specimens in order to get the weight and the dry weight. So basically, we dry these specimens all night, and then we measure to get the water content. And
thank you. Let me just interrupt. Thank you. I noticed that you wrote that this is something relatively new in humans. It has been done in animals, but you are attempting this in humans. Now, I just wondered, is it difficult? Do you feel confident about the result? I know that some outliers, some people that are, very high or very low. Do you think that may that be part of technical issues with the procedure, or do you think that the procedure is okay, even though it's new, and that these outliers are true observations? What do you think? Just what your feeling is.
Yes, thank you for the question. So I say that when we have outliers, we had really outliers. We just remove them, since the sodium concentration was from the biology point of view, not real. So in this case, we know that, of course, there was a technical problem. Okay. But oh yes, in this case, we had also outliers. It's true, and what my feeling is that we repeated the experiments in another cohort of patients that I did not mention in my presentation, and interesting, the results were more or less the same. So we are in the same range of concentrations.
Okay, thank you. That's fine. And then you have dry weight and you have water. So yeah. What do you think is included in the dry weight? Is that cells? Is that also some extracellular matrix? What is the dry weight? What does it represent?
Yes, thank you for the question. This is one of the issue that with our team we are exploring, and because yes, it's a mix of course, of cellular and extracellular components. So we were well aware of this, and we took when we took the biopsies, we do not include the hypodermal tissue that can be different, for example, between men and women. And so, of course, it is a good question, but in my view, taking the epidermis and the superficial derma make these differences very small from one patient to another. But of course, this is my feeling. It's not proved. To overcome this problem, we now are taking the biopsies, and we cut it half for to do hematoxylin and eosin staining in order to be sure of which part of the skin we are evaluating.
Okay, thank you. And I think a final question. Now, if you compare, let's say, figures 4 and 5, you see these cross-sectional comparisons between people with primary aldosteronism and perhaps two sets of controls. There are the true controls and there are people with essential hypertension. Now, and then you have in figure 6 and also figure 7, you have the before-after comparison. Now, I guess that what you expect is that after adrenalectomy, people return to normal, right? That's what you expect.
Yeah.
But actually they don't, do they? Because there are quite a number of differences between the situation after adrenalectomy and the controls in the other figure. For example, just one example, and I would like to ask your comment about that. For example, in figure 4, there is no difference in water content. But in figure 6, for example, the water content actually increases after adrenalectomy. So they are not like normal. You would have expected no change, as if you take figure 4 as the normal situation. And another example is, for example, figure 5a, where you have an increase in skin sodium. But in figure 7a, you have not a decrease in skin sodium, which you would have expected, but you actually have, if anything, no change, but perhaps even a slight increase. So by and large, if you compare all these figures, the people after adrenalectomy do not return to like the control situation, do they? What is your thinking about that?
You may give a short answer, please.
Yes. Okay. This was one of the problem that has to be solved, in particular for the water content. That is our next point, our next task to understand. One of the possibility is that we studied these patients before adrenalectomy with MR antagonist, so with a diuretic. So perhaps maybe this could have affected these results. Okay. So now we are taking a biopsy with MR antagonist before adrenalectomy, without MR antagonist for adrenalectomy, and 1 month after another biopsy. So 3 biopsy to at least exclude this problem. And the other possibility is
thank you. I think that's a very good answer. Thank you for that, and I'll give the word back to the prorector.
Thank you.
Thank you, Professor Stehauer. The opposition will be continued by Professor Hamelder. He is a professor of internal medicine, in particular nephrology, at Maastricht University. Professor Hamelder.
Thank you, Mr. Prorector. Dear candidate, also my congratulations to you and your team for the completion of the thesis. And I will discuss with you first on chapter 2, in which you show the results of adrenectomy on patients who you have selected for unilateral PA. And these results are quite impressive if you look on the long-term outcomes in your patients, but I think it's rather important to discuss how you come to your selection of patients, because you did it with an adrenalus venous sampling method, and you described that you didn't stimulate it with cosyntropin, in which you referred to the AVIS-2 study, and you also used a cutoff value for the selectivity index of 2 to select your patients. Can you explain why you choose for that cutoff value? Because I know from the AVIS-2 study that they suggested to use a lower cutoff value.
Highly esteemed opponent, thank you for the comment. Yes, we did a non-stimulated AVS, and as you mentioned in the AVIS-2 study, we showed that using the cosyntropin stimulation, about 30% of patients who really have a unilateral lateralization were not would be not included in the unilateral would not be submitted to unilateral adrenalectomy. And so it's true, we found an even lesser cutoff. So we choose to use 2 as a cutoff index in this study, because basically it was a proof of concept study. So these patients were resistant hypertensive patients on multiple interfering drugs, and so we went to we can say a more a little more conservative index for both selectivity and lateralization.
And since you know now your results of your proof of principle, do you recommend to change the cutoff value for the clinical practice?
Yes, if we based our if we look at our findings of this proof of concept study, maybe yes, since the patients are remain at a high cardiovascular risk, so to give them a chance to resolve their blood pressure resistant to treatment by AVS-guided adrenalectomy, I think is we can say a risk that we have to go through.
And do you have an indication how many patients of your group of 52 patients which you didn't let undergo surgery, how much of those 52 patients had a cutoff value between 1.4 and 2.0? Because I think that's the interesting group. If you are capable to select also those patients with some good results on surgery, you get a better result for the whole group of patients with resistant hypertension. Do you know how many patients you had in that window?
No, from that window, no. But this is a suggestion to do it in this cohort of patients that do not lateralize higher, we can say, at higher index.
Okay, I will be very interested to see if you had an other result if you change the cutoff, but I will progress to chapter 3, in which you studied the quality of life effects of your adrenalectomy in the patients with APA, and I was rather surprised to see. I will look for it. It's about just a moment. It's about figure 1 at page 61, in which you show the results on quality of life measurements in PA patients, and you compare it to control patients who also get surgery on the adrenal tumor which they had, and you see only a small difference between the PA patients and the controls on the physical component score at 6 months after surgery. Are you also surprised about this observation you made, and how do you judge this inside of the literature on this issue?
So the fact that the controls did not have an amelioration after surgery for the physical component, or for
no, I mean I was rather surprised that you saw a very little effect of on the physical component score in the PA patient group at baseline, and then you saw a very light increase of that, but you saw the largest effect is on mental outcome and depression outcome, and that both are comparable in the both groups.
Yes. So maybe for the reason that we do not find any differences between PA and controls, maybe is for the fact that both these groups underwent a surgical treatment. So maybe these two this population where we can say experience the same procedure that can affect these results. And for the physical component, where there are studies that showed also an increase in the physical component. Maybe at 1 month follow-up after surgery, we were not able to see any difference. Maybe because it was we can say the time was short to see an amelioration of the physical component. For the mental component.
Thank you for your answer. I wouldn't expect that the time was too short, but I think the problem is in the baseline measurement, because I think you had to measure quality of life more earlier before surgery than you did now, but we can discuss later on it. I give back the word to the pro-rector.
Thank you.
Thank you, Professor Hamelder. The next opponent is Professor De Leeuw. He is Professor of Internal Medicine at Maastricht University. Professor De Leeuw.
Thank you, Mr. Pro-Rector. Signora Torresan, prima di tutto vorrei congratularmi con lei per il vostro lavoro. Ma
Grazie.
devo fare una domanda, come la sai. So I shall continue in English so that your promoter can also follow our discussions. And I have a few questions for you, and we will start rather easily. And that's about the following. You say that we have to check patients with resistant hypertension for primary aldosteronism. But at the same time, you say that all kinds of clinical clues can be absent and the condition is underdiagnosed. So what is your feeling about the proposition that maybe we should screen many more patients, hypertensive patients, for primary aldosteronism, and not only the ones who are resistant on treatment?
Highly esteemed opponent, thank you for the question. Yes, of course, as a surgeon, I see constantly the benefit that these patients have after surgery. So I think that study these patients for primary aldosteronism when they have resistant hypertension, maybe for several reasons is too late. So in fact, the clinical outcome, for example, is impacted on the it depends on the duration of hypertension. And so my feeling is that if we are able to screen these patients, especially young patients, for a secondary cause of hypertension, that it probably is expensive, but at long term it will become less expensive. So as I mentioned in my presentation, we can really improve morbidity and mortality related to hypertension.
Okay, so there is a case to explore whether it's feasible and useful and economically useful.
Yes, and also with this this study about hypertension and other studies, also by our group in Padova, we showed that during the aldosterone renin ratio is the best method to screen for primary aldosteronism, and also if these patients are on multiple drugs. That is, I can see it in practice that most of the time is difficult for
I'll see your point. Yeah, thank you. Then I would like to go to the chapter on the adrenal venous sampling, and I have two questions about that. First of all, you had a lot of patients, and then in 25 patients you had unambiguous evidence, as you stated, of unilateral aldosteronism diagnosed by the sampling. My question is, if you go back to these patients, wouldn't you have detected these patients with imaging alone as well? I mean, did AVS really contribute to the detection of the patients that you would have missed or maybe also diagnosed with CT or MR? And a second question related to the sampling is that we know, of course, that plasma aldosterone levels can vary tremendously, even if over a short period of time. And that could also be the case with the levels in the adrenal venous effluent. And that has to do of course, with the question whether there is continuous or episodic secretion of aldosterone. So the question is, what is your opinion about this AVS in terms of variability in aldosterone release and the possibility that it may confound your results?
Thank you for the question. So for the first question, the imaging, the issue of imaging or AVS is still a debate in the literature, and what can I say? I can say that these patients also, based on the guidelines, these patients.
I understand that reasoning, but the question really is, did you really have to do the sampling in these patients? Would you have detected these patients also if you had relied solely on imaging?
The answer is no, since these patients were old, and so some of them have negative or bilateral nodules at imaging. So without that is normal to find in the old population. So unless we studied it also in the AVIS 2 study for the imaging, we saw that probably if we would rely only at imaging, we wrongly remove the adrenal in about 40% of patients. So yes, we say as surgeons, knowing this, we will not remove the adrenal in patients older than 40 years old or more, as in our selection.
Yeah. Okay. But now that you mention older patients, that brings me to another point that you know, of course, that there is now this this problem of the clusters of aldosterone-producing cells, which are more prevalent with increasing age. Does that, to some extent, confound the issue of the sampling?
A short answer, please.
Okay. Or in our probably in the older patients, but we focused on our core patients. These patients had a nodule visible on CT images. So not all the times, but most of the time, it is concordant with the AVS result, the lateralization. So I think that
but because the rector probably doesn't allow me to go on, can you just state shortly, is the aldosterone secretion episodic or continuous?
Sorry,
Is it episodic, the secretion of aldosterone, or continuous?
Is episodic.
Okay. Thank you very much. I'll give the floor back to the pro-rector.
Thank you, Professor De Leeuw. The opposition will be continued by Professor Basso. She is Professor of Pathological Anatomy at the University of Padova in Italy. Professor Basso.
Okay. Thank you. I also enjoyed to read this thesis with a very addressing many aspects of resistant hypertension. Of course, my background is cardiovascular system. So I was attracted particularly by chapter 2, dealing with the resolution of drug-resistant hypertension by adrenal vein sampling guided adrenalectomy. And really the results as reported are amazing, because it seems that you can have cardiac and renal organ damage regression after adrenalectomy. And can you just discuss a little bit more this cardiac organ regression? How did you check these and which are the real results?
Okay. Highly esteemed opponent, thank you for the question. Yes, we did the echocardiography in all the ultrasounds in all these patients before and after adrenalectomy. So the results showed a significant regression of the left ventricular mass index, and in these patients, and also a significant increase in we can say the remodeling of the atrium size. So basically these patients had then a lower risk after removing the excess of aldosterone, a less risk of, for example, atrial fibrillation, which is more common in patients with primary aldosteronism. And so these patients had a clear cardiac remodeling after adrenalectomy.
If you look particularly to table 3, I mean, how do you explain that the left ventricular hypertrophy didn't go completely to normal values after adrenalectomy? Is there an explanation for this? Left ventricular hypertrophy.
Yes, if there is an explanation of why they return to the normal. Yes.
Not completely to normal values.
Yes, this is. Thank you for the question. So, of course, the removing the cause, so the excess of aldosterone, give an amelioration of the cardiac damage, but probably the other factors contribute to this cardiac damage. For example, the long term, the long time of hypertension that sometimes these patients had. So this is why the clinical outcome probably do not completely was not cured in patients were not completely cured by clinical outcome. So they still on antihypertensive medication or have high blood pressure. So they need antihypertensive medication. So they are biochemically cured, but not clinically cured. And maybe this the issue of salt accumulation with the salt accumulation in the interstitium that I studied in chapter 4 can be a one of the possible explanation of this. And so we are now exploring this this problem with the magnetic resonance to see, for example, tissue images, if the water content, how these patients had a change in water content in the myocardial tissue. And this is a nice field, I think, to explore, since, for example, in hemodialytic patients, where we remove salt and water with the dialysis, we saw a change in the water of in the myocardial edema, but also in a change in the fibrosis that could be perhaps related to the mechanism that I showed, so the inflammation induced by an excess edema. So I think that is an interesting thing.
Okay, you preceded my next question about cardiac MRI, but to the table 3 is my last question. This is concentrated on morphological evaluation of cardiac regression remodeling. Do you have any data about electrocardiographic changes in this patient before and after adrenalectomy? Of course, you mentioned atrial fibrillation, but I mean the value of cardiac hypertrophy, left ventricular hypertrophy. If not, it could be a next, of course, evaluation. Do you have any data about?
I do not have, but yes, except for the atrial fibrillation, for example. But maybe our team have this data, but we can check also for this in the future.
Okay, thank you.
Thank you.
Thank you, Professor Basso. The opposition will be continued by Dr. Spiering. He is Associate Professor of Vascular Internal Medicine at the University Medical Center in Utrecht. Professor Spiering.
Thank you, Mr. Prorector. Dear candidates, I also would like to congratulate you with your thesis on this very important subject. I would also congratulate your supervisors in your team. And I would like to discuss with you chapter 5, which has not been discussed yet, on the skin sodium storage in fibromuscular dysplasia, in short FMD, and its relationship with blood pressure variability. Can you explain to me why you think that FMD patients have a higher blood pressure variability?
Esteemed or highly esteemed opponent, thank you for the question. Yes, fibrobascular dysplasia is a complex disease, and we can have different phenotypes of this disease. So unifocal fibromuscular dysplasia or multifocal example. So I think that study this the blood pressure variability, we did it in a retrospective study for the renal fibromuscular dysplasia. So the short-term variability in the blood pressure variability is one of the marker that is linked to an cardiovascular risk. So I think that to study these patients for the blood pressure variability and the relationship between the activation of the renin-angiotensin system in these patients and combine these results with the skin sodium accumulation can be an interesting study.
So if I may interrupt you, so you raised already the point of the renin-angiotensin system in these patients. So I quite often see patients with FMD, and I also measure renin and aldosterone in these patients. And quite often renin and aldosterone are normal. But in your hypothesis, you state that there is an excessive aldosterone production in these patients. Do you think that with these findings that this justifies your hypothesis?
Oh, I think, thank you for the question. I think that maybe one of the possible explanation why renin and aldosterone are not high is that the time when we measure aldosterone and renin. So if we measure it maybe in the first phase of the stenosis, probably the renin and the aldosterone are higher than in a second or a later phase, maybe. But it is interestingly that after revascularization, these patients have less lower values of blood pressure. So even if the renin remain, we can say, at the same levels. So maybe other mechanisms can be involved in this, and I think that combining all these findings can be a good, a nice study to do.
Yeah, I think that it's very important to state that renin and angiotensin levels are not the whole story in the hypertension in FMD patients. It's more complex than we think. So let me continue on because this chapter is more a proposal of a study that you would like to do. And I was struck about the very small number of patients that you have calculated for your study. So 6 patients in each group with a very high statistical power of, I quote, 99.84%. So in 2 times 6 patients. Can you explain how you would like to achieve this very low number of patients needed with a very high statistical power?
Okay, so you mean in chapter 5? Yes. In the protocol. So can you repeat the question? Sorry.
Yeah. So no problem. So you need only 6 patients in each group, and then still you have a very high statistical power. So normally you need more patients, and also the statistical power can become an issue if you have small number of patients. So it's more about the technique that you are using. Is the technique so sensitive and is the variability so low that you can justify 6 patients in each group?
Well, thank you for the questions. Maybe our previous finding in the skin sodium in primary aldosteronism is the results showed that maybe the number of patients is probably low. so we have to increase the number, because to see the differences to get a statistical power like this, we have to include more patients in the analysis. Yes, this is true, and this is true also because we, as I said before, we repeated the experiments in other with primary aldosteronism, and so the mean sodium content is not so.
So thank you for
to see a difference is not.
For the sake of time, thank you for this question. For this answer, I would like to go to chapter 2 again. This is, I think, the most debated chapter in your thesis. So the first simple question is, what is your definition of PA?
Sorry, the definition?
What is your definition of primary aldosteronism? What's the definition?
Primary aldosteronism is the most prevalent of secondary.
So how is it diagnosed?
How is it? Okay, by aldosterone renin ratio. So these patients have at least one clue of primary aldosteronism, that is hypokalemia, or evidence at imaging of a nodule in the adrenal, or have obstructive sleep apnea.
Mrs. Torresan, I'm sure that you have noticed that the time for defending your thesis has passed. The committee will now withdraw to discuss the quality of your thesis and the quality of your defense, and please await our return with the results of our deliberation.
Thank you.
I see that everyone is back. Mrs. Torresan, the degree committee here present online has assessed the quality of your thesis and the quality of your defense today. And in view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Kroon is authorized to confer upon you this academic distinction in accordance with Dutch university custom and law. And I invite your supervisor now to take the floor. Professor Kroon.
Of scientific integrity at all times, to be careful and honest, transparent, independent and responsible.
Yes, I promise.
By the authority then vested in us by law and in the conformity with the decision of the committee here present online, I hereby confer upon you, Francesca Torresan, the degree of doctor and grant you all rights attached by law and custom. As evidence of this, you will soon receive the degree certificate signed by the rector, by the secretary and by the supervisor affixed with the official seal of the university, and it will now be shown by the beadle.
Thanks.
Dear Dr. Torresan, dear Francesca, as your Maastricht supervisor, I want to congratulate you with this major accomplishment. You considered your PhD thesis as a great achievement, and here you have done it. And you did it in a way not many of your colleagues can say they did. You have a double graduation, both in Maastricht and in Padua. A thesis like yours marks the collaboration between our two universities, and you can be proud to be part of that. This and some other graduations this thesis and some others may be viewed as the starting point of something even bigger. We are trying to establish a European hypertension school now, and starting from Padua and Maastricht, and now adding Paris, Glasgow, and Madrid in a project that is called Mindshift. We try to establish a larger European hypertension school to give hypertension research a large boost. But back to you. You're an endocrine surgeon and you really like to do clinical research. As a clinician, it's very difficult to find time to do your research besides your clinical duties. I know that by my own duties. Notwithstanding that, you have put a lot of effort in your research project recent years. And unfortunately, the corona pandemic didn't support you, so to say, but you continued with iron discipline. I was told that the project on skin sodium is your favorite. You spent a lot of time in collecting skin samples and analyzing data of patients with primary hyperaldo. The skin project is also where we found each other. As you know, I'm involved in a lot of patients with fibromuscular dysplasia and seeing them because of their hypertension. Then the combination was easily found. Sampling skin biopsies in FMD patients and establishing the role of hypertension in these patients. And although due to corona, the skin biopsies in Maastricht haven't been gathered yet, I have the confidence that we will accomplish that, and probably this will be in the Mindshift project. I really enjoyed your stay in Maastricht. You managed to find your way in our university quickly together with your friend Valeria. You two both deserve a special management annotation in establishing our encounters and discussions, which, so to say, were not always that easy. As said, it is your intention to continue your clinical research and to pursue an academic career. It is very sad that your father cannot witness this event. He is one who always believed in you. He died not so long ago. You dedicated your thesis to him, but with your determination and your father in mind, I'm sure you can become a great endocrine surgeon and do a lot of new and interesting research. Again, my congratulations to you and to your nearest families. Now I'll give the word to your other supervisor, Professor Rossi.
Thank you, Professor Krohn. I think I should add very little to what you said very, very nicely about Francesca. I could tell perhaps something about her personality and the contact that we had on a daily basis in our work, although she works under Professor Iacobone officially and most of the time. When I allowed Francesca's recruitment in the PhD program, I must admit that I was really skeptical about her performance because our previous experiences with surgeons were really disappointing. But Francesca did very well in proving me wrong in the sense that she was very passionate and committed to research. She's a very fast learning person, and on a personal basis, it was very pleasant to collaborate with her. She made a very strong choice in her career, which was to abandon a quiet career as a surgeon in the hospital to stay in research. And I think Francesca is a very rare breed of surgeons who will bring surgery to a next level of sophistication. So the questions she received were very tough. I thought she couldn't be able to die satisfactorily, but again, she proved me wrong. And I think this graduation will be an asset for her for the years to come and will be really an investment for the scientific community. I hope she will be able to continue her collaboration with Maastricht University and particularly with Professor Krohn in the fibromuscular dysphagia. And this will produce data that will make our understanding of hypertension pathophysiology much better than now. So congratulations, Francesca. You were hit very heavily by life, not only by coronavirus, which precluded a longer stay for you in Maastricht, but also on the personal ground. But I'm sure that your dad will be proud of you. So congratulations.
Just few words also from me. I would congratulate with you, Francesca. We know since a very, very long time now, as Professor Krohn and as Professor Rossi have underlined, life was very, very hard, especially during the recent years. I think that you have really demonstrated that surgeons are not so basic, finally, as I previously mentioned to the committee. I hope that you will have the possibility to stay in the research field, in the endocrine surgery research field, and the previous years have gone. I hope that the future will be very better and reaches of satisfaction for all of us. Thank you, Francesca.
Highly esteemed Dr. Torresan, dear Francesca, it's my great pleasure to congratulate you with your doctorate and honor that you have required today. I do that also on behalf of the Board of Deans of Maastricht University. And I would also like to share some impressions of the committee with you. We have seen a clear presentation, and we have also seen a thesis which represents an appreciable amount of research. And we are also aware of that not all the studies that you have done could be included into the manuscript and into the thesis. And the committee appreciates your innovative studies and also an indication of your future studies. And in your defense, we saw that you are knowledgeable in the field, and we have seen an adequate defense. And also we have seen reflections, and these reflections might have been also been included in your thesis. And again, I congratulate not only you with this result, as we have seen today, but also your three supervisors, Professor Bram Kroon, Professor Gian Paoli Rossi, and Professor Jacobone. I congratulate you with the very good results that we have seen today in the form of a thesis and in the form of a very good defense. I include, of course, in my congratulations, your family, in particular your mother and your colleagues and friends, and all those who have contributed to all your studies that you have performed. And I wish you a very successful professional career and a happy personal life.
Thanks.
Before I close this ceremony, I would like to thank all the members of this degree committee, and also which includes also the members of the thesis assessment committee. And in particular, I thank the external members and all opponents for their questions and the interesting scientific and academic discussions. Maastricht University appreciates your contributions. And hereby I close this academic ceremony.